Hi friends, today let us learn about an important topic named rickets. In rickets is one of the most common metabolic disorder. It occurs due to defective mineralization of the bone matrix. So if rickets is seen during growth period, it is known as osteomalacia. But if it occurs before epiphyseal fusion, it is known as rickets. So let's learn now why vitamin D and about the role of vitamin D in rickets. Vitamin D can lead to growth retardation, and it is also associated with expansion of the growth plate due to expansion of the hypertrophic chondrocyte layer. I know you might have not understood what about this hypertrophic chondrocyte layer, so let us learn about that. Normally a normal growth plate has three layers. They are the reserve layer, the proliferating layer, and the hypertrophic chondrocyte layer. So in rickets you will see that this hypertrophic chondrocyte layer is more commonly involved. This hypertrophic chondrocyte layer is more commonly involved in rickets. Now let's learn about the causes of rickets. In rickets, it occurs due to defective intake of calcium, vitamin D, poor exposure to sunlight. Optimum levels of vitamin D are more than 25 nanograms per ml. You can see vitamin D deficiency is more commonly associated with malabsorptions like celiac disease or hepatic osteodystrophy. Okay. In renal diseases, primary diseases causing rickets are glomerular disease and renal osteodystrophy. The available forms of vitamin D are in two forms: exogenous form of vitamin D and endogenous form of vitamin D. The endogenous form of vitamin D is usually stored in skin as cholecalciferol. So this cholecalciferol is nothing but it is a product of cholesterol metabolism. It's a byproduct of cholesterol metabolism. So this cholecalciferol is also known as vitamin D3, whereas D2 is known as ergocalciferol. So in this, let's learn. We have already covered regarding the causes. So in causes, you have to remember two more important things is mainly due to defective intake of calcium, vitamin D, poor exposure to sunlight. Also associated with malabsorptions like celiac disease and renal diseases. So let's learn about the bone changes. In rickets, you can see that bone becomes soft and spongy. Bowing occurs body weight. So you can observe that even under the body weight, the legs usually become bent. You remember mnemonic named as bent. So you will see bowing of legs even under the body weight. So that is seen in rickets. And you can also see that normally the epiphyseal line is 2 mm thick, which is surrounded regularly by cartilage. But what happens in rickets is this line becomes wide and irregular. It is in epiphysis. Now let's learn what happens in the metaphysis. At metaphyseal part, usually becomes thick, broad and irregular. Why it becomes thick is because of the proliferation of the growth plate cells. And one important feature which you can see definitely for rickets is you can see cupping at the wrist epiphysis. It's one of the most important point. And you can also see swellings are prominent at the costochondral junction. In the costochondral junction, in the lung x-rays, you can see very commonly that there is beaded appearance. It's known as ractic rosary or rickettsia rosary. Okay, you can some of the other features are like you can see bossing of forehead. Forehead usually becomes square and prominent. Exaggerated curvature of the spinal cord is nothing but lumbar, also known as lumbar lordosis. Pelvis usually seen flattened, but in osteomalacia you can see it is trifoil in shape. Next comes is femur. Femur is usually seen which is bent anterolaterally. Neck shaft angle of the femur is diminished, known as coxa vara, which is very, very important. Coxa vara is seen in rickets. Knees can either undergo genu valgum, also known as knock knees, or it can also undergo genu varum, which is nothing but bowing of legs. Tibia is also bent anterolaterally. Long bones of the lower limbs are usually bent. So as femur, tibia, both of them are bent. Now comes clinical features. Now you can see a child coming to OP, usually at between age 7 to 8 years of poor socio-economic status are usually come to OP. Child usually, how you will have a doubt like how to identify if that the patient is having rickets, because the child can't tell, it is only 7 to 8 years. So one of the most common thing is child usually looks irritable, does not sleep properly, does not play actively, patient can have delayed dentation, delayed walking, secondary anemias, skin usually looks dull, poor muscle tone, child does not develop proper height, and irregular bowels. So let's learn detailedly about the clinical features from head to toe. So in the skull, you can see bossing of the forehead, prominent parietal bone, flattening of the skull and vertex. You can also see that patient can also have open fontanelles, craniotapes. This is one of the prominent features seen in rickets. What is craniotapes? You might be having a doubt. So craniotapes is nothing but skull bone becomes thin and cracky due to softening at certain areas. This is known as craniotapes. Patient looks dull. Now comes skin changes. In skin changes, skin usually becomes flabby and subcutaneous tissue is also involved. Chest. You can see that the patient might present with pigeon chest. In pigeon chest is nothing but anterior-posterior diameter is more when compared to transverse diameter in the chest. Rhactic rosary, as I've already told you, these are nothing but costochondral junction swellings. They usually appear beaded in appearance. You can also see Harrison sulcus. Harrison sulcus is nothing but it is a depression which is usually seen at the lower areas of the ribs. It occurs due to pull of the diaphragm by the ribs. So you can see Harrison sulcus. So these are the features which you will remember regarding chest. So in the next comes is abdomen. In abdomen, you can see that the patient might present with like protuberant abdomen, separation of the rectus muscle. Then comes bones. In bones, you can see cupping at wrist epiphysis. In the femur, as I already told you, you can see coxa vara, diminished neck shaft angle of the femur. Femur is bent anterolaterally. In comes to tibia. Tibia, you can see tibia is also bent anterolaterally. In knees, you can see that both the knees either undergo genovalgum or genovarum. Genovalgum is known as knock knees. Genovarum is known as bowing of legs. Valgum is valgus, coming together, sticking together. So it can lead to knock knees. Genovarum, it can lead to bowing of legs. So otherwise, it can also lead to one leg in valgum and other leg in varus. This is known as Winswift deformity, deformed legs. So now next learn about the pathogenesis in rickets. In rickets, there is failure of deposition of calcium and phosphorus in osteoid tissue. So because of this failure of deposition of calcium and phosphorus in the osteoid tissue, in the lab findings, always calcium and phosphate come together in rickets. So in rickets, you can see calcium levels are decreased, phosphate levels are also decreased. Next comes what is increased, alkaline phosphatase levels are also increased. So remember always that in rickets, calcium is decreased, phosphate is decreased, but alkaline phosphatase levels are increased. Now comes this management. In management, you will provide good nutritious diet, less cereals, more milk, cheese and nuts. Then you'll start prescribing injections for patients like vitamin D injection, a single shot of 6 lakh units you'll give initially. Then after 4 weeks, you will again repeat a dose, give again 6 lakh units. Then you might be having a doubt whether the patient has been recovering or no. Just get an X-ray done. If you see sclerosis is seen around the metaphyseal growth plate line, then you can, this indicates that the patient is recovering. So you can keep the patient, you can shift the patient to a maintenance dose. So what will be the maintenance dose? You'll keep a maintenance dose of 400 international units are given daily. But if you see, second scenario, if you see that if the patient is not having any line of sclerosis, if the patient is not recovering, and if you see that there is no sclerosis seen at the metaphyseal growth plate region, then this is known as refractory rickets. Refractory rickets we'll learn in another topic. It is a separate entity. Now comes next is deformities which are seen in rickets. Deformities, how will you correct the deformities? You might be having bowing of legs or knock knees or anything. So initially, we can't go for osteotomies. First, we have to do either splinting and manipulation with reduction with serial castings. Still, if the deformities are persisting even after splinting and even after doing consecutive manipulative reductions, even if still deformities are persistent, then you have to go for osteotomies only after failure of medical management. So I hope you understood about rickets well. So in next class, we'll learn about other topic. Till then, take care. Bye.